is Barb Cochran. I'm the Associate Director for the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this lecture series. This is the last lecture in the winter 2019 series, and this is a rescheduled lecture from those days when we had the snow cancellations that are now thankfully a bit of a distant memory. But we really appreciate Angela Hanson coming back and rescheduling. So I do want to mention a couple of things. If you haven't signed up for continuing education credit for this series, but have been attending, you can still do so, and your site coordinator should have the information for signing up. If you are wanting to look at any of the past lectures in the series, they're posted, I think almost all but one, are posted on our Northwest GWEC website. That's nwgwec.org, and I'll get the rest of them posted within the next week. We are launching our spring lecture series starting April 2, same time as this winter series. However, I do want to let you know that the Alaska sites, if you're one of the Alaska sites, they will not be participating in the spring lecture series. So just a heads up on that. Otherwise, we will have 10 lectures that are focused on more general geriatrics topics starting April 2. And you can get continuing education credits for those as well. And now I'd like to introduce Angela Hanson. She is an assistant professor in the Division of Gerontology and Geriatric Medicine in the School of Medicine. She says that her goal is to become an established investigator in the field of Alzheimer's disease and dementia prevention, so very suitable for this Alzheimer's disease and related dementias series. As a logical extension of her research fellowship and her clinical experience in the memory disorders clinics, she also has a deep interest in how dietary factors modulate cognition in Alzheimer's disease biomarkers. Specifically, she's interested in how the Alzheimer's disease genetic risk factor ApoE4 modulates cognitive and biomarker responses to diet and diet-related therapeutics such as intranasal insulin. In 2015, she received a Career Development Award to investigate how ApoE genotype affects lipid transport and subsequent clearance of amyloid breakdown products in response to high-fat feeding. And this work has had important implications not only for Alzheimer's disease therapy, but also clinical practice, as different diets and treatments may be indicated for people with different genotypes to promote optimal cognition. So she has tremendous expertise in various areas of Alzheimer's disease. Today, however, she is going to be talking with us on an overview of dementia diagnosis with a bit of an emphasis on early dementia diagnosis. And welcome, Dr. Hanson.
All right, thank you for having me. Can everyone hear me? I'm not muted over here. Oh, great. So thank you. I'd like to thank the Northwest Geriatric Workforce Enhancement Center for inviting me to speak and give this talk to the world. And thank you for the kind introduction. I do research, I'm in the throes of grant writing right now and thinking about glucose and biochemistry, so this is kind of a nice break. One day a week I do sit in a dementia clinic doing real practical care for older adults, so it's kind of a nice, I have a foot in both worlds, so to speak. So hopefully we'll have plenty of time for questions. I know Dr. Thielke also spoke to you a little bit about this talk. I think this will complement and add to that, I hope. And hopefully it won't be against it at all. Yeah, so I wanted to start out with resources. If you don't remember anything from this talk other than the first line of it, alz.org or the Alzheimer's Association is just a fantastic organization, and the resources that they have online and also in their offices when they are present is just amazing. So, and they even have resources on all kinds of dementias. So from early stage Like, how do I know what normal memory is, all the way to I'm a caregiver for someone with advanced dementia. What do I do if they're having trouble with their bladder? So just the whole spectrum of dementia and research and resources in a 24-hour hotline. So alz.org, easy to remember. You can look a lot of stuff up there. And then just some other organizations for you to know about. There's a Lewy Body Disease Association, Frontotemporal Dementia Association, and good for those patients and their caregivers. We have a website, and you can sign up for our newsletter on the website. There's a HRSA dementia curriculum put on by the NIH. And then area agencies on aging, for those of you practicing outside of King County, or even within King County, there's an area agency on aging here. My understanding is there should be an area agency on aging in every county in the US. I know for sure Washington, I'm not less familiar with other states, but they will have resources and help for you. So these are the objectives. If we will hopefully get through these, I'd like to discuss the importance of diagnosing and documenting cognitive impairment. I'd like to teach you a little bit about the workup if a patient does have cognitive impairment. Know the criteria for the most common forms of dementia that you'll see out there, and then a brief overview of the medications we use for Alzheimer's. That's a lot. So, okay. So here's part one. So I do a lot of teaching, and I teach primary care residents. So they're going to be the front lines of caring for older adults with dementia. And I made up a case, but this could be very real. It's based on real cases. So we have a 75-year-old man with hypertension, GERD. He's new to your clinic. He wants to discuss, so he has his list. He wants to discuss medications, his seasonal allergies, and his heartburn. You want to discuss his blood pressure. Near the end of so you're getting ready to prescribe a blood pressure agent for him because he's not controlled quite well, and it's 2 minutes to the end of the visit, and the daughter says, I'm worried about my dad's memory. He might not be taking his medication properly. Does he have dementia? And I mean, you're like, I have a minute left now for this visit. What do I do? So kind of panic mode. And I made up this case again to be kind of like stressful, to just show you how dementia just kind of intersects and kind of crashes into the care that you want to provide for your patients. So we'll talk more about Mr. Jones in a bit. So there's some barriers, I think, to diagnosing dementia. We vary, and I apologize, this is physician-centric because I teach residents, but just healthcare providers in general, we vary in our ability to diagnose and document symptomatic dementia. So not even screening for it, but just documenting that they have it. I used to be a hospitalist, and I joke that I'd get records about the patients admitted to the hospital, and I would know their ejection fraction to the decimal point, but it wouldn't be documented in their chart that they had dementia, where it was kind of clear that everyone knew that they had it. So there's a lack of knowledge about how to formally diagnose it, lack of protocols, lack of time. Time is a huge factor. We have 80 minutes for our new patients, and I'll tell you that's barely enough time. So I can't imagine if you are a real doctor doing real health. And I mean, I'm a real doctor, but we have very luxurious time to make this diagnosis in a specialty clinic at a very sophisticated hospital that kind of dedicates time to that. It's an enormous amount of time. Kind of an opinion that specialists should do this. And then of course, if you don't have that specialist in your area, that's harder. There's this kind of discussion about screening for asymptomatic disease versus active case finding. I think sometimes when people talk about screening for dementia, they might be talking about looking for early signs of it when the patient's actually normal. Whereas what I'm talking about is really active case finding. So like asking them if they drink. So if they're drinking in a harmful way at home, they're already doing that. And just because you didn't screen for it and find it out, I mean, that just makes you not thorough. So I want to emphasize that active case finding of patients that are having difficulty with memory is not the same as screening for an asymptomatic disease. And there's some kind of nuances to both of that. But what I'm talking about is really your active case finding. They're having memory loss, and it is impacting their life, and they're forgetting their medications. They're driving potentially unsafely, and we don't ask. I think that's not being thorough. Concerned about the negative impact of the diagnosis. The flip side of this is, if they're not doing so badly, is it so bad that we don't talk about the memory loss? There's not a lot of treatment there's very few treatment options. There's certainly no cure for most of the forms of dementia that are out there. So it's a tough illness to deal with. It really is. And I feel for that aspect of it. But I would say that delayed diagnosis has some negative consequences. So it's a missed opportunity to identify contributing factors and potential beneficial treatments. You have uninformed hospital or consult care providers. So maybe you kind of know they have memory loss and you kind of deal with it, but then you refer this patient to a complicated, procedure, and that proceduralist doesn't know they have memory loss. One study showed that 42% of acute medical admissions over 70 had dementia by diagnostic criteria, but only half of those had it in their chart at the time. So again, they have, if they're in the hospital, you need to know if they have dementia so you can make their care plan more accurate. Of course, it changes the care plan. It's a game changer. So Mr. Jones, he had hypertension, seasonal allergies, and GERD, and then potentially dementia. And of those 4 diseases, one of them is a huge game changer for how his whole life goes. Well, they all could potentially, but you can't really trust the medical history as much. You need a simpler medication regimen. You need to make sure their caregiver, if they have a caregiver, is informed. And then goals of care may change. It's a missed opportunity for advanced care planning. If someone has advanced dementia, they're not able to fill out a POST form, they're not able to fill out advanced directives or appoint a durable power of attorney, but they can do that in the moderate stages or even the early stages. If they can say who their loved ones are and what they want, even if they don't remember the details of their medical disease, they can speak to who they are and what they want. So I think, of course, I'm a little biased, but I think it's important to diagnose early. So, people come to my clinic already screening in. Somebody worried about their memory or they're worried about their memory. So they've already kind of screened in. So once they hit our clinic, we're already doing the fancier tests. But if you're doing primary care and you're taking care of a lot of older adults, I think it's useful to implement some kind of screening or some kind of dipstick test, if you will, to see, should I be worried about memory or not? Yes or no. So here's some short screening tests that only take 3 to 6 minutes. The mini-cog was developed by Dr. Borson here in Seattle and her colleagues. It's 3-item recall plus a clock draw. I think people are pretty familiar with it here because of where it was developed. And then the 88 is actually a questionnaire. It's 8 questions that a caregiver fills out, and the patient doesn't have to be there at all. It's all of the caregiver assessment. And then a GP cog is kind of a combination. Lots of other tests. My little pearl is I do like the mini cog because it has that clock. And I'll tell you how many caregivers or even patients have said, oh, I forgot a word. No big deal. Who cares, right? But if someone has trouble drawing a clock, it's more visual for patients and families, and they can say, oh, there is something kind of wrong here. It's not just that they weren't paying attention and forgot a word. We all forget words and names and stuff. And they're easy to administer. So these are good screening. So you might consider them as a part of a geriatric practice, or do a quick one if someone's worried about their memory. Of course, in our clinic, like I said, people have already screened in. They essentially failed the mini-cog just by walking in our door and saying they're worried about their memory. So we do a longer test. We try to do a MOCA on everyone. So of course, in Seattle, you talk about MOCAs and then you want to drink a mocha. It's the Montreal Cognitive Assessment, and it's harder. It's the hardest one of all of these. And so it's good screening for early stage or for a really kind of highly educated population, and it's very sensitive for MCI. And it's less biased for cultural and education level than the MMSE. You see the MMSE I have on here, I kind of crossed it out. You know, it's proprietary. You can't scan those forms in unless you buy the rights. And it's just less sensitive. So MOCA is what we use. There are other ones, and if you prefer the other ones, so the short blessed test is a little bit easier and quicker. So if your clinic is busy, that might not be a bad idea. The RUDAS has a more praxis and less affected by language. So if you have a really big non-English speaking population, that might be good. And then the SLUMS, it has a terrible acronym. It's a St. Louis exam. And this one's been really validated in the VA. So I see the VA veterans come in with this. So, I mean, the short answer is there's no right or wrong answer to this, except maybe I would say the MMSE is probably the wrong one to use. But use one, get comfortable with it, and just stick with it. And then just be aware of what you're testing. If they have visual or hearing impairment, you aren't necessarily getting at their cognition, you know, obviously. And then non-English speaking patients, the mocatest.org is translated. I think it's even more languages than this now. I should update this slide. But they translate the words directly. So the words are face, velvet, church, daisy, red. And velvet is translated weird in some languages. It takes them like a minute to say some phrase that means velvet. And I'm thinking, what is this testing in Cambodian order? So just be kind of skeptical of some of the language components. If they're scoring low but functioning pretty well, you know, there may be just some caveats. But anyway, it's a lot of fun to do that. And for some reason, a lot of people call the rhino a hippo. I don't know. It's just a thing. So what I would say is I think it's important to identify patients with cognitive impairment. We're actively case finding now. You know, we're looking for people who are having the disease, just like we're looking for people with heart failure when we ask, are you short of breath? That kind of thing. If a patient is worried about their memory, or if a caregiver, like our daughter of Mr. Jones, said, I'm worried about my dad's memory, he's screened in, you know, so he needs an assessment, or at least a little, like a thought process. Like if someone said they had chest pain, you know, you'd kind of roll out your stuff. And so I would pick one or two tests and just know them well, document it. And then what I tell my residents, I say, set aside a visit. And you know what, when I present Mr. Jones, they almost always say this, that. And so they're learning a lot of good stuff in the residency. They say, oh yeah, he needs to come back for a full visit to assess that. They didn't say they would try to squeeze it all in that last minute. So I think that's good. All right. So what do we do in our clinic besides run late and ask a lot of questions? Okay, so I talked about the mini cog. This is Salvador Dali. This is his clock. I'm not sure what his diagnosis was. But, Mr. Jones struggles with your clock draw at that second visit. He draws a clock similar to the middle one. So it's mostly right, it's not quite right. And he only remembered one of three words, banana, but he forgot sunrise and he forgot chair. I'll ace all of the memory tests, by the way, because I've done them a million times. So I think about cognitive impairment like a geriatrician. It is a geriatric syndrome. And it can be a syndrome in younger people too, but especially in older adults, cognition or cognitive impairment is a geriatric syndrome with a lot of contributing factors. You have your neurologic diseases. The pink circle is part of that, but it's not the only thing. And medical diseases, you know, diabetes that's all out of whack, medications either that we prescribe or that they obtain, psychiatric conditions, and then social supports. What I see a lot of times in my clinic is, oh, they were doing just fine until they moved to Seattle to be near me. And all of a sudden their memory got bad. Well, maybe they were having memory trouble before in their Florida home, but they, you know, adapted well. And now all of a sudden in a new environment, it's very clear that they're having trouble learning new things. So what I do in my clinic, I'm looking for reversible causes, contributing factors, and ultimately trying to answer, does this patient have a neuro dementing illness. So those are kind of the three things I try to do in that 80-minute luxury visit that I get. So reversible causes. You'll learn about this in medical school or nursing school, and I have to say, I hardly ever find a reversible cause and a cure for someone's memory loss and send them away and they're better, like on an episode of House. But it does happen, and we do have to check for those things. Much more likely, I find what are called, oh, and let me go back. When I do find a reversible cause, it's almost always a medication. So there's that. But what I do find almost every visit is a contributing factor. So they have Alzheimer's and, they have cognitive aging and things that are going on. So medications they're on, they're not getting sleep, they have comorbid depression. And so if you optimize a lot of those things, although you cannot cure their Alzheimer's, you may improve their quality of life and extend their ability to live at home. But ultimately, at the end of the visit, and at the end of that gaze of Mr. Jones' daughter, does my loved one have dementia? That's the money question. That's what they want to know. And what I tell my families is, this is a journey. It's a little bit like being an attorney. You got to make a case for or against it. There's not usually one test that rules it in or out, although a PET scan kind of does, but we'll get there. And it's okay to be unsure. It's okay to diagnose over time. It's okay to talk about memory loss and kind of ease them into the diagnosis of Alzheimer's. So those are kind of ways that I talk about it. In order to know if someone has a neurodegenerative disease or not, we have to be able to distinguish dementia from normal aging. And that's not always easy to do. There's a wide variability in cognitive ability at baseline and also in the decline that we do see with age. What I would say is the general truths about aging and cognition is that we do have a general slowing of cognitive performance, and we have a decrease in our mental flexibility. We have some difficulties finding the right word. We have a little bit of a decrease in our short-term or working memory, but we usually remember that we don't remember. So we have insight. We have intact memory for current events in our past. We remain independent in our ADLs and IADLs as we age, with some, again, variability with that, given the impact of technology, and we retain our verbal abilities and we retain our vocabulary for the most part quite a ways into the illness, except for certain forms of dementia. And we take advantage of that when we do cognitive testing. And then changes in perceptual systems or speed of processing can influence attention and memory, and it can influence how we test it. So, if you're asking someone and then you want them to respond really, really quickly, and there's distractions and there's, codes coming over the PA at the VA, there's a code green or something. So that you have to take those things into account when you're diagnosing this. So kind of getting back to the MOCA test, if they can't hear your questions, then that's not really a fair test. But these all kind of impact your patient, and so sorting these out can be hard. This is a slide from the Institute of Medicine. There was a retirement study. It's a longitudinal study of older adults, the health and retirement study, that's what it is. And this is a cognitive test that goes up to 100 points. It's a little bit more extensive than the MOCA. And this is the composite score. And what we're looking at is the red line is the average cognitive score, and then the standard deviations are in blue. And first and foremost, look at the variability on the y-axis. Some people start really high and some people start lower. And so we all have kind of a baseline level where we're at with cognition. And then it declines over time, although some people improve over time. So there's a lot of variability, and we retain our cognitive ability for a pretty long time. You see a dip at age 80, and that's very likely to be people with dementia driving down that average. But if you don't develop dementia, your cognition stays pretty stable. So I think that's good news for our older adults, the worried well, if you will. And that's what we're shooting for with normal aging. I stole this from the Alzheimer's Association, alz.org. If you have people that are worried about normal aging or dementia, this is a good website to pull up. Making a bad decision once in a while, missing a monthly payment, forgetting which day it is and remembering later, forgetting a word, sometimes needing help with electronics or the banking system, or they can't remember their 90th password they had to create. That's me. They do need more time and energy to encode new information and less distractors. So, but they can learn. Whereas dementia is poor judgment, can't keep track of a budget or the season, and they have less insight into their difficulties. They lose something and then they just get agitated, or they forget a word and they can't process and then they forget what they were going to say. All right, so that's normal aging. And then there's dementia, but there's of course a stage in between that we call MCI, or mild cognitive impairment. Oops. Oh. And, you know, mild cognitive impairment is sort of a, you know, intermediate diagnosis. And just like any staging of a continuous variable, you know, it's like, well, is it MCI or early dementia now? And, you know, I think it's not always easy to know when they've crossed over, and it kind of depends on the patient. If they're still working, they're going to notice differences in their cognition if they're not, for example. But the official definition of MCI is they can still carry out their everyday activities. And not all MCI progresses to dementia. Sometimes it could be depression or sleep apnea or those kind of things. So these are patients where we might find reversible causes that can get better. And these were just some of the factors that the HRSA module suggests. And we certainly ask about these in our clinic. We certainly will know if they have diabetes. We do screen for that if indicated. You know, vascular risk factors, alcohol, renal failure, depression. So when is it dementia? So I know Dr. Thielke covered some of this already. Dementia is cognitive impairment that you've formally assessed. It's a decline from their previous level of function. It's interfering with their ability to do work or hobbies. You've excluded delirium and major psych disorders, and you've distinguished it from normal aging. So that's really the key. We talk about cognitive domains, and there's quite a few, and this is where neuropsych testing becomes really handy if you have access to that. They have a lot more time that they can do more extensive testing if you're especially a younger person or an older person that you're just not sure if this is dementia or not, and their MRI is just kind of, well, I don't know. They can really drill down and look at the different domains. So attention, there's different kinds of attention. Sustained attention versus divided attention or multitasking. Learning and memory, amnestic. So amnestic, you hear that word a lot in my field, amnestic MCI or amnesia or whatever. Amnesia in the movies is fantastic, right? They don't remember their name and it's super dramatic. Like that never happens ever. Like we always remember I shouldn't say never. I'm sure there's a case report here or there, but how they do amnesia in the movies is just not correct. It's just, we don't remember where we parked our car, or, you know, we do start forgetting our loved ones and things like that at the very end stages. But yeah, movie amnesia, movie medical stuff in general, as you probably know, you have to get the bullet out. No, you don't. It's just stop the bleeding. Anyway, okay, don't get me started. But what amnestic is the difficulty remembering new information. So Alzheimer's disease is really characterized by amnestic memory loss, and that's difficulty learning, taking, you know, we are constantly bombarded with information. If we're in a caveman day or if we're in modern day, like all that information is important, and our brain has said, you know what, most of this information is junk. We don't need to know it. We only need to know the important stuff. So here's how we consolidate important stuff, and here's how we filter the rest. And the hippocampus and the temporal structures are really important in recognize, first allowing you to pay attention to the world, and then figuring out what you need to remember and not, and then laying down memories that you need. And the hippocampus is key for gnosis, I guess. And when that goes awry, we have amnestic learning. And signs of that are repeating questions over and over, misplacing things, forgetting appointments, forgetting where you put stuff. Executive function, this is probably the most important part of dementia, but it's the hardest to test. It's what makes us human, sort of our ability to plan, sequence things, have judgment about the world, and there's a variability of that at baseline, right? And then it can decline. We do have some ways of testing this, but I think the most important way to test this is to talk to the caregiver and ask them how they're doing and get concrete examples of what they're doing out in the world. Language, of course, is the easiest to test. You can just ask them to repeat and learn new words. Visuospatial, this is often impaired in things like Lewy body disease. I ask about, do you have trouble recognizing faces? And there's actually tests you can do online for that. Do you have trouble seeing objects that are right in front of you? And I don't mean like finding something in the fridge. I'll try to avoid making jokes about my husband. Like, it's right there. No, but seeing things that are in direct view. So if it's behind something, you're not expected to see it, but you do have to move stuff to look. Orienting clothes to the body. So like getting dressed and not being able to figure out what way that shirt goes. So that would be visuospatial memory. Of course, driving, finding your way around. Personality and behavior. So this can go awry in all the dementias, particularly late, but it goes awry early in frontotemporal dementia. And you can get either apathy and social withdrawal, or you can get socially unacceptable behavior. So, people talk about losing your filter. And, I said a little bit earlier, we have a little bit more rigid thinking as we get older, and we might lose a little bit of that filter. But if a grandma that used to love holding her grandkids all of a sudden doesn't want anything to do with her grandkids or something, that might be an example of a change in her personality that's quite dramatic. And then social cognition. So what I tell my patients, so here's just kind of a review of the different domains. Neuropsych testing can kind of help identify patterns, or taking a history and documenting, where the domains go awry. But it's never 100% accurate. I mean, there's just a lot of bleed over between. So, but neuropsych testing can sometimes help clinch a diagnosis. All right, so what is the minimum to-do list if you're going to tackle this, and make a diagnosis or try to decide if someone has dementia? So timing and collateral information. As with most diagnoses, the history is the most important piece. And I've had patients, especially if they come alone, instead of ordering, well, I wouldn't say instead of ordering, I mean, this is the memory clinic. We order a lot of MRIs. But almost as important, or maybe more important than ordering tests, is getting that collateral information. So if you didn't get that at your first visit with the family all sitting there, I will make a call to either a caregiver, like with their permission, of course, or to their doctor. I had a patient where I just wasn't sure if this was malingering or there was just weird story. And I called the primary care doctor who knew this patient for years and said, oh yeah, this is new for him. And that call to the primary care doctor and just like a 5-minute conversation was really, really informative. So spend that time, or if you have people that you can, you have a student working with you to track that down, get the information. And then on physical exam, I'm looking for, again, those contributing factors. I'm looking for heart failure, untreated lung disease, but for the actual diagnosis portion, I'm looking for their neuro and psych findings. A formal test of cognition is almost always very helpful. So like I said, we do a MOCA in our clinic. What labs do you send? You might get a lot of variability on this. I work at Harborview, and so I do tend to send more of the RPR, syphilis screen and HIV screen if they have risk factors, or I'm just not sure. But I think some of the guidelines would say, you know, B12 and TSH for sure, and then other tests as appropriate. So again, what you're looking for is reversible causes like B12 deficiency or thyroid, hypothyroid. And then what I'm also looking for is contributing factors, and also making sure their liver and kidney function are okay if I start prescribing medications. So if someone hasn't had a CBC and a CMP, I just kind of want it. I am an internist still, so I like to see those. We do get a lot of imaging in our clinic. We'll talk about that. Who to refer, we'll kind of talk a little bit too, but if this is atypical, if they're rapid onset, if you think they need an EEG, if you think they need to see a neurologist, you know, send them to a neurologist. That's completely appropriate. Or, you know, a clinic like ours where we have neurologists. This is a slide I have at the very beginning of the resident talk that I give. And this is a topic that I continue to learn. And if I have a particularly tough interaction with a patient and family, and I have a resident with me, I'll ask them, like, what do you think? Should I have done something different here? But this is sort of what I've learned over the years of doing this memory kind of care, is that first and foremost, always try to do patient-centered care as much as possible. I always have the patient sitting next to me, and even if I'm mostly talking to the caregiver, I bring it back to the patient. So I start with the patient always, how are you doing? I'm going to get your history. And then because you're having memory loss, it's nice to get collateral. I say, it's nice to phone a friend, call, you know, and then everyone laughs. So try to put them at ease. And then for a follow-up visit, what I will do is I will let, especially if they have moderate dementia, you know, I'll still try to engage that caregiver. So the daughter's worried that Mr. Jones isn't taking his medication. Says, well, Mr. Jones, it sounds like we need to get you more help with your medication. I'm going to ask your daughter to help you with it. So I'm talking to her, but I'm talking to him. I think that's worked really well, but it takes some practice, and I'm still working on optimizing it. And then the other thing that I do is, you know, and this kind of depends on your family and things like that. And there will be occasionally times where the family just doesn't want to, or the patient doesn't want to know the diagnosis or something. But I think 900 times out of 900 times really, we talk about, like, the patient gets the diagnosis and we don't withhold information or whatever. But one thing that I do, so we aren't constantly saying the A word or the D word, Alzheimer's and dementia, I say memory loss. Everybody's okay with being told they have memory loss. I mean, sometimes they aren't, but hey, Mr. Jones, because you have that memory loss trouble, I think we need to do this. Instead of saying, because you have Alzheimer's. So I do tell them they have it and it's on their chart. But when we're talking day to day, we don't have to use the word. And I think about that with cancer. If you're talking with your cancer care provider about your nausea, they don't have, well, because you have cancer and you have nausea, I'm going to prescribe a medication. You know, they don't have to say the C word to manage the day-to-day symptoms. So anyway, and I model that for the family. You know what I used to do at the VA? I'd have a patient and I'd want to interview them alone, or the caregiver alone. And so I'd have my nurse like take the patient on a pulse ox check and walk them around. And then I'd talk to the wife. And there was some dynamics too there that made it hard. A lot of more kind of traditional family structures with the patient being the man and the, you know, But, you know, kind of looking back, I probably could have had a lot more of those conversations with the patient in the room had I had the skills to do that. So it's okay to talk about it. It's okay to model that care. I'm going to skip a couple, I'm going to just move through a couple of these slides a little quickly. I would say, what I'd say about the neuro exam is the eyes and the walking are really your important piece, because you're looking for some of the more atypical dementias. So with supranuclear palsy, you have trouble looking up and down. With Parkinson's or Lewy body dementia, you're having trouble with walking and you have increased tone. Those are kind of the biggies. But they don't need a full, like, head to toe hour-long neuro exam. You can kind of do a quick and dirty one to rule some of these out. The psych exam, you already did the psych exam when you brought your patient back to the room. Their appearance, are they disheveled? Are they well dressed? Are they in comfortable clothes? That makes you think, oh, maybe it's hard, the caregiver is actually having to address the patient. What is their mood? Are they having word finding trouble? What are they focused on? Do they appear to be hallucinating? So your usual psych exam. I'm going to go through the next few slides just a little bit more quickly because I know that Dr. Thielke did cover a lot of this. And do you guys get the slides from? Yeah, so you can kind of look through these. But here's the key for all neurodegenerative diseases. They start years and decades before you have symptoms. So, which is disheartening if you're trying to cure them and prevent them. But it's important to know that when you're diagnosing these. So these are biomarkers that go up. So the red line, so A beta goes up, then you have tau, then you have brain structure, which is an MRI, and then you have memory, and then you have clinical function. So if someone has really subtle memory loss, some of those biomarkers might be normal appearing. Other biomarkers might be really high where someone doesn't have symptoms. So the biomarkers are challenging. You have to kind of think about them longitudinally. And what I'd say about imaging, most guidelines do recommend imaging for a new diagnosis of dementia. We almost always get an MRI because it's superior at looking for smaller strokes, the hippocampus, cerebellar disease, and things like that. But be aware that MRI might be normal in very early stages. And the functional tests like PET scan or SPECT scan are more sensitive if you really want to look for dementia. So I do this with my residents. So I tell my resident, you already know what the MRI report is going to be in Mr. Jones. I forget how old I said he was. But 80-year-old man, what's his MRI going to show? You've already read this report 100 times. It's like non-specific, mild to moderate atrophy, appropriate for age, or they might say correlate with age, evidence of cerebral white. Well, what does that mean? Like, so unhelpful. So be aware. A report might say appropriate for age for 65 and 95. You could take the same MRI with the same level of atrophy and someone go, oh, they're old, sure they are atrophy. But significant temporal wasting in a 65-year-old is not normal at all. And 95, sure, it might be. So be aware that look at the MRIs and yourself and just be aware that they don't standardize those volumes. It's all kind of clinical gestalt. And then again, I talked about the MRI might appear normal. I talked a little bit about neuropsych testing. I'm going to just skip a little bit ahead just so we make sure we have time for questions. So I'm going to talk about the criteria for the most common forms of dementia. Okay, so people can kind of think about this in your mind and those on the phone or those in the internet. What is the most common cause? Give me your top 3 causes of dementia in your mind. So kind of think what this list is going to be. So top seed is Alzheimer's. So this is the most common form of dementia. If you think they have Alzheimer's, they might have Alzheimer's. I mean, it's so common. Keep thinking about it. If it's atypical, still could be Alzheimer's. If they're a little younger, still could be Alzheimer's. So it's very, very common. And then the next top 2 and 3, I would say, are Lewy body dementia / Parkinson's disease dementia as an entity. And then the next one would be vascular. Some people put vascular, as number 2, and Lewy body's number 3. But these are like the top 3. So Alzheimer's is really common. The next 2 common ones are these guys. And then there's all the other rare stuff. That's kind of how I would think about it. So these are some of your other diagnoses you might see in clinic. So kind of like I talked about before with the domains, things don't always add up. So you have what the textbook says, and then you have reality. And reality is a mess. They have other diseases, they have psych diagnoses. They've had bipolar forever, and how does that affect this? And oh my goodness. So just always think about what their clinical symptoms are and what would a pathologist find if they snuck in and grabbed a piece of the brain, and would they line up or not? And a lot of times it's not, but sometimes, you know, they line up enough to make these valid diagnoses, but just be aware that there's a lot of variability in the human brain. And also in our older population, we can have more than one thing. So they can have multiple etiologies, like Alzheimer's and Lewy body, or Alzheimer's and vascular. Those are really common to have both. So diagnosis of Alzheimer's disease, we think about it in 3 stages. Preclinical, that's a research definition, and you probably won't see that, but maybe they enrolled in a study and a doctor told them they had amyloid plaques, and you're like, what do I do? Mild cognitive impairment we talked about, and for those of you that operate with the DSM, that's the mild neurocognitive disorder in the DSM-5. And then there's Alzheimer's dementia, or major neurocognitive disorder in the DSM-5. And then we talk about probable and possible. And then we stage dementia similarly to how Dr. Thielke talked about mild, moderate, and severe. There are fast stages that you may have heard about, and you can pull those up, and you do need those for hospice criteria. But in my clinical day-to-day management, I don't usually think about the fast criteria unless I have to put it in a note or something. Alzheimer's, I said it was the most common, and I said it's almost always Alzheimer's, unless they're young. So less than age 60 and they don't have a family history, Alzheimer's is rare. Alzheimer's is again, they have to meet criteria for general dementia. So just like a mental illness. Is this bipolar or depression, whatever? Well, first they have to have, it's interfering with their life. Is it interfering with your life? Is it a decline? And then they usually need at least 2 domains, inability to acquire and remember new information. So the amnestic presentation that we talked about. There is a variant of Alzheimer's called posterior cortical atrophy, which is exactly what it says it is. And then you have visuospatial because your occipital lobe has atrophied. It might be out there. Usually language is not that impaired until the end, but sometimes Alzheimer's can be, you can have a language variant Alzheimer's where it's almost like as if they had a stroke, but progressive. And then of course, judgment and personality. Usually those are a little bit later. Really it's that amnestic, asking questions over and over and misplacing things a lot. That's usually your first symptom. Okay. Oh, the other thing I'd say is for Alzheimer's especially, and the other diseases, it should have an insidious onset and progressive course. Now, sometimes people say it seemed to start overnight. Then you really want to dig. Like, okay, but how were they and then you look and they got an MRI 2 years ago and the indication was for memory loss. Like, oh, I thought you said this started a year ago. And usually it's a really painful question. Like, well, when did this start? Well, a year ago. Are you sure? Well, 2 years. And it's just so hard to pin down because remember, it came on insidiously. It's like hair growing long. Like, when did it get too long where you need to cut it? It's hard to say because it just grows a little bit every day. Then you need criteria for general dementia. So you have so here's brain slices. On the left you have normal. Yeah, on the left you have normal brain. And on the right, it's atrophied globally, but particularly atrophied in the temporal area in the hippocampus. There's a huge space there where a brain tissue used to be. And we can identify that on a coronal section in an MRI. So stroke protocol or epilepsy protocol or just ask for coronal sections through the hippocampus and you'll get it. And you can see there the atrophy is pretty severe in that hippocampal area. So what I'll say about vascular dementia is very quickly, you can get vascular dementia kind of 1 in 2 ways. One, you have a big stroke and it's not a diagnostic dilemma whatsoever. And then 2, you can have insidious vascular wear and tear on the brain that causes executive dysfunction and memory loss. Not unlike Alzheimer's, but it's not overnight. And here's an example of an MRI of someone that has vascular dementia without a frank stroke. So this was an 82-year-old man with slowly progressive memory impairment. He could have a little Alzheimer's too, you know, if you looked for amyloid, but this was a case of vascular dementia. So Lewy body dementia or disease, these are fairly new criteria. They've been updated a little bit. So the core features are fluctuating cognition with variation in attention and alertness, recurrent well-formed visual hallucinations. REM sleep behavior disorder is now a core feature instead of a supporting feature. And Parkinsonism features, which are slowness of movement, falls, bradykinesia, tremors. The teaching is that if you have Parkinson's disease for a long, long time, and then you develop cognitive impairment, that's called Parkinson's disease with dementia. And honestly, I think a lot of those people have Alzheimer's too. If you have cognitive impairment and Parkinson's within a year of each other, that's called Lewy body. So the year is the cutoff. But there's a lot of comorbid Alzheimer's, as you could imagine, because these folks are older. They do respond better to the drugs, the Alzheimer's drugs actually, but they do have a worse prognosis in terms of time, time to death from diagnosis. They're more impaired on attention, executive function, visuospatial, and they have more atrophy in the posterior area and some other areas. So a PET scan or an MRI might be able to help. An MRI early on looks pretty normal. And this is just the, what do we mean by fluctuating cognition? It's not just good days and bad days. They're almost delirious one day and then the next day they're super alert. Or they almost seem like they're having seizures. And if you sent this person for an EEG, you wouldn't be wrong. In fact, a lot of them get an EEG. So frontotemporal dementia, if we cure Alzheimer's tomorrow, this is what I would study. This is so fascinating. It's a fascinating illness because it really affects our behavior and our personality. It makes you wonder about how humans are. Anyway, this is as common as Alzheimer's in younger patients. Mean age of onset 58. It's more likely to be genetic. It overlaps with ALS in some families. So I always ask about just general neurologic diseases in my family history. And then there's two main variants. Behavioral variant FTD is the most common variant. If you've seen FTD, you've probably seen that. And it is often mistaken for mental illness. So a 60-year-old that has new onset schizophrenia or bipolar, be skeptical and make sure we've ruled out dementia because it won't respond to the medication the way that schizophrenia would. Language variant can be subtle early on. So here's how I think about frontotemporal dementia. So frontotemporal dementia is a MRI diagnosis kind of, right? Frontotemporal dementia. And then the behavioral variants. And then there are variants within those. So behavioral variant FTD, and then there's kind of like these other tauopathies. So progressive supranuclear palsy is also tauopathy. So there's tau tangles, but there's not plaques. So it's not Alzheimer's. Corticobascular degeneration. And actually, TBI or CTE might be in here as well. That's kind of being worked out right now. Dementia caused by repeated head blows. And then you have primary progressive aphasia. I love the names of these things because it tells you what it is. It's primary, it's progressive aphasia. And then there's different variants that I don't even really memorize, but just be aware that they're, this is where you'd send folks for neuropsych testing. And if someone has progressive aphasia, well, if they come to you with aphasia, the first thing you're probably going to do is you're going to think this could be a stroke and you're going to get an MRI. And so an MRI might tell you, oh, they didn't have a stroke, but they have some frontal atrophy. But if their MRI is pretty normal, still consider FTD in the differential because it could be the MRI is normal, but the signaling it just hasn't atrophied enough yet to show up. Behavioral variant, you need 3 of 6 criteria. So early behavioral disinhibition. So the grandma who just doesn't want to hug her grandkids anymore, acting bizarre, impulsive, early apathy, loss of empathy, and decreased response to others' needs. Early perseverative compulsive behavior or speech. And then there's kind of this tie-in with the appetite center. So hyperorality, they might actually binge eat or really crave carbs or something, and it's a change, or crave sweets. Or you might even have pica. I've heard of cases where people are eating out of the garbage and things like that. And then their neuropsych profile, their memory is actually not so bad, but their executive function is off. I had a patient who, she presented to the ER and she said, I am selling my body for methamphetamines. She wasn't doing any of those things. I mean, it was just the weirdest story. And of course they you-toxed her, and it's, you know, she's living with her husband, but she just has these weird, bizarre behaviors. But she remembered, all sorts of stuff. So if you have the disease long enough, you'll have the atrophy. And then this is a PET scan. So you can see the PET scan asymmetric. So you have PET scan is how well does the brain take up glucose? And it should take it up good. That's all it cares about. It takes up a quarter of our glucose, goes straight to the brain. The rest of it, then all the other organs get the rest. But you can see here that there's an asymmetric loss of a signal. And then it's in the frontal and temporal lobes. And then this is a sagittal view is great because the frontal and temporal lobes will be problematic in FTD, temporal parietal in Alzheimer's, and posterior in Lewy body. So like I go to that image first and I can just kind of look front to back to try to make a diagnosis. I'm going to skip CTE for now just for time. So there's, you guys will have in your, and we can talk more about it in the questions if needed, but CTE is kind of a working diagnosis right now. It's complicated. What I would say is it's complicated, but it's definitely, we're going to learn a lot more about this next couple of years. If they're still drinking and they have memory loss, the treatment is they need to stop drinking. It just, abstinence is your first, second, third, and fourth plan for this patient. I wouldn't put them on any medication. I mean, you can check a B12 and of course all that kind of stuff too, but I wouldn't treat them with any medication, or even maybe, maybe consider imaging, but they need to stop drinking. Normal pressure hydrocephalus is a condition where you have increased ventricles, and it causes a combination of trouble with a gait, cognitive difficulty, and bladder issues, and the treatment can be a shunt. So that's one of the, I would say it's sort of a reversible dementia, although I have to say once you develop cognitive impairment from NPH, the cognitive impairment doesn't usually completely go away. Their gait gets better, their bladder somewhat gets better, and their cognition stabilizes a little bit, but it hardly ever returns back to normal. So they probably have, I know it's going to sound like boring, they probably had accelerated Alzheimer's from whatever was going on with the brain. Rapidly progressive is normal to dementia in 2 years. Okay, I see a lot of patients in my clinic. When did this all start? Oh, about a year ago. And their MoCA is like 10. Thinking, oh, really? And then I go, I'm really skeptical. Like, was it really a year ago? And again, they had the MRI 3 years ago in the chart, and they had memory loss. Again, be skeptical. But sometimes you really do get a history of like, no, they were working, they were doing this, and then within a year now they're impaired, they can't live on independently. Then that person needs a more rapid workup with a neurologist or ER, or depending on the situation. And then there's just like a million things it could be. Fortunately or unfortunately, I don't know which one, but I don't see a lot of this because a lot of times these folks will end up in the hospital rather than a clinic. But a good medical history, a basic set of labs and an MRI will rule out like 90% of these. So you don't have to worry about sending every single one of these tests. And the history, of course, is going to guide you a ton. So what I would say is formally diagnosed dementia, you want to work up in a standardized way, know when to refer. And if you know those top 3 dementias and that they can be mixed and that you partner over time and you're comfortable with a little uncertainty, I think you'll do okay trying to diagnose this on your own. Now I want to just briefly talk about meds and then we'll have time for questions. Okay, I got to show a synapse because it's cool. So this is a neurosynapse. Obviously, the neuron is packaging acetylcholine, And then there's acetylcholinesterase that chews it up so that the signal goes away. So this is how it's supposed to work. Drugs that are procholine, like donepezil or Aricept, what it does is it blocks the enzyme that breaks down acetylcholine. So acetylcholinesterase inhibitors inhibit the breakdown of acetylcholine, improving neurotransmission of cholinergic neurons, in theory, and supposed to help the brain function better. Anticholinergics do the opposite. They are a competitive inhibitor of acetylcholine, blocking neurotransmission of cholinergic neurons, such as Benadryl, Detrol, amitriptyline, your bladder medicines, some antidepressants like amitriptyline. And some SSRIs have a little bit of anticholinergic side effect in there. So multiple studies are now showing a fairly strong association with being on these drugs for over a year and developing MCI or Alzheimer's. It may actually be a risk factor. It may actually be that if you inhibit this synapse long enough, that synapse atrophies and goes away. So that's scary a little bit to me. One of the good things is a lot of anticholinergic medications are not life-saving. They're not insulin or they're not cardiac meds. They're medicines that treat symptoms. And certainly the symptoms can be very disabling for patients, but often there are non-pharmacologic or other alternatives. Certainly for antidepressants, there's alternatives. For sleeping, there's alternatives. So a lot of anticholinergics are probably unnecessary in older adults. So I just think we should stop or reduce them as much as possible, given that. What do we use for Alzheimer's for drugs? There are 4 approved drugs, not counting combo pills and stuff. So there's 3 acetylcholinesterase inhibitors. So donepezil is Aricept, galantamine is Razidine, and rivastigmine or Exelon, which comes in a patch. So I always start with donepezil. If they have GI side effects, I might switch to one of the other ones if we think they need to stay on it. And then if patches are better than pills for compliance, we do that. Side effects, nausea, diarrhea, vivid dreams. I do warn patients about this. Most patients don't have nightmares. They just report their dreams are more vivid, or maybe they're just remembering their dreams. I don't know. Anyway, certainly you want to ask if they have nightmares. You take it in the morning, or you might reduce or stop. And then side effects we worry about are bradycardia, syncope, and falls, which of course is not insignificant in our population. They don't have a lot of drug-drug interactions, so that's good. Memantine or Namenda is kind of like a hand-wavy drug. Like I showed you really fancy pictures. We know exactly what acetylcholinesterase inhibitors do, at least in theory. Namenda is kind of like, well, it's a NMDA receptor antagonist, which does something. I don't know if we really know. It doesn't cause the bradycardia. So if someone's a cardiac patient or on beta blockers or whatnot, this is safer. But it also can cause nausea, vomiting. And again, minimal drug-drug interactions. Not surprisingly, drug companies have not published guidelines on how to stop their medications. I'm sort of being sarcastic there. Obviously, they haven't. I start them. So Dr. Silke and I have an ongoing discussion about this, and he studies like when should we stop these medications, and he's a big believer in that these medications really have, except for maybe Lewy body dementia, he's not convinced by the evidence for that they treat Alzheimer's disease at least in the large majority of patients. They have just a lot of side effects and things like that. I have to say that just sort of in my practice, I do think there are subgroups of patients that seem to benefit from the Alzheimer's medication. They're symptomatic medications. They don't cure the disease. They don't alter plaques and tangles. But there seems to be a group of patients that seem to respond, and there's no way to know who is and isn't. So we'll try them. We'll set goals and check in. If we don't think it's helping, we can stop it. And then for Lewy body dementia, like I said, the hallucinations in particular tend to respond to the medication. So we push it. in those folks. Just putting the resources at the end again. And then I hope we have lots of time for questions. So thank you so much for your attention.
Questions from the room, I'll get that. If they have questions in the room, I will need you to repeat them.
Oh, yes.
Otherwise, I do have a couple here. So, first of all, one of the attendees said, just to let you know that when screening for dementia, you should probably look for a history of physical brain injury, TBI. The reason I make this comment is because socially inappropriate behavior is common in certain brain injuries. Additionally, some brain injuries do affect the patient's ability to move their eyes up and down.
Oh, good. Yes. So I guess you probably all heard that, but just to be aware that when we're screening for dementia or diagnosing it, asking about TBI, that's a good question. So we do ask about TBI, and it is certainly a part of our clinical history. And what I would say about TBI is there's sort of, I think about it in kind of two ways. One is if someone has a traumatic brain injury and then has clear cognitive impairment after that, again, that's not a big diagnostic dilemma. And we actually don't see very many of those patients because they're handled by rehab medicine at Harborview. It's just kind of a nuance of Harborview is if they have TBI, they go to rehab. If they have not TBI, all the other stuff comes to us. So we don't manage TBI patients that have a known TBI and then a direct cognitive impairment after that. So for what it's worth, you know, we don't do those patients. What we will do is mild TBI that recovered, and then 10 years later, now they're developing like progressive symptoms, and is this now Alzheimer's in addition to everything else? And what I'd say, or we have patients with cognitive impairment and they've had traumatic brain injuries in their past, but I have to say we don't know how to take those histories or know what to do with that information directly. So I fell off a ladder twice in my 20s and 30s and I was knocked out, but then I lived forever after that and I was fine. Like, and their MRI doesn't show any scar tissue. So like, we don't know what we're looking for. You know, we write it down and we think that's certainly noteworthy. But in terms of mild TBI or concussion history, now I would say repeated head injury is kind of a whole different animal. And we have, again, we usually send those like NFL players and things like that do sometimes come to our clinic, but usually we send those to rehab medicine. So there's kind of like a disconnect between like what those folks are doing and then what we're doing in our clinic where we see much more milder forms of it. So stay tuned, and we're trying to learn and know how to incorporate that. And I guess the other thing I would do is, you know, I'm not only a doctor, but I'm a citizen, and I vote and I advocate, and head injury is just bad, and we should do everything we can to avoid it, from seatbelts to helmet laws to, you know, hoping the NFL changes some of their policies and all that good stuff. So anyway, off the soapbox.
And so here's an interesting question. I have a lot of patients who cannot see or hear very well. What screening tool would you recommend? I feel the MoCA and others are not a good representation when a person cannot see or hear very well.
Yeah, good question. So what do we do with hearing impairment and vision impairment? So I'll tackle them a little bit individually. So there are tests that can accommodate one or the other. And certainly a neuropsych testing, particularly if they're still otherwise pretty functional, would certainly be appropriate. There are definitely more visual tests that can accommodate hearing loss and vice versa. If you have both, I think you are going to be a little bit more limited in what kind of tests that you're going to do with the patient. And I'd probably pull out the 88 and ask the caregiver. So hopefully they have a caregiver that can tell you about how they have been doing. And of course, if their loved one's doing all their ADLs and IADLs because they can't see, you know, it's going to be hard, you know, hard to know, tease a little bit of that out from dementia. But I would say the 88 is what I would use.
And someone has said they're unfamiliar with the term tau. Could you say a bit more about that?
Oh, yes. I apologize. I should have spent a little more time on that. the tau is a intraneuronal protein. It's a part of the axon filaments. And in Alzheimer's disease and several other dementias, you have tau gets phosphorylated abnormally, and then it aggregates and causes tangles inside the neurons, and then eventually those neurons will die. And so tauopathies include frontotemporal dementia. Alzheimer's disease is a tauopathy because there's tau tangles there. And head trauma and CTE, chronic traumatic encephalopathy, has tau tangles in there as well. And so right now there's no way to look for tau well, that's not true. If you want to look for tau, you can look in someone's spinal fluid. So spinal fluid can tell you if there's amyloid changes. Amyloid actually goes down, and then tau actually goes up in Alzheimer's. But oddly enough, in all the other tauopathies that are pure tau, their spinal fluid is kind of a mess. It's not as clean that it always goes up in the CSF. So you can't really diagnose that. We're working on tau imaging, so that may come in the next couple of years, but not yet.
Is white matter disease a dementia diagnosis?
Good question. So is white matter disease a dementia diagnosis? I would say no, white matter disease. So white matter changes on an MRI. It's a finding, just like atrophy is a finding. And I would say it only makes the diagnosis if there is a lot of it. Where'd it go? So there are formal criteria to diagnose vascular dementia based on extensive periventricular white matter lesions. But what do they mean by extensive? And how do you the first two on this list are pretty easy to count, that the third is, but when is it extensive and when is it not? I think more likely what we have is we have someone with symptoms, and then we get an MRI and they have a lot of white matter disease and they don't have a lot of anything else, then I do diagnose those patients with vascular dementia based on those findings. So white matter hyperintensities are really common. We see them a lot, but they can be a part of a diagnosis in the right setting. I don't know if that answered the question, but what I would say is, I wouldn't, if let's say you get an MRI for another reason and you see a lot of white matter hyperintensities and you go, oh, they have dementia. Dementia, remember, is always a clinical diagnosis, and the MRI is kind of trying to tell you why. So the way I think about it is the MRI tells you like what the name of the diagnosis is, but doesn't tell you how severe it is or even if they have dementia. It tells you what the diagnosis is if you've already diagnosed them with dementia. So.
You mentioned stopping anticholinergics. Does this also mean breathing inhalers? And they can hear me asking the question.
Yeah, fair enough. So I don't need to, it's just my habit. Like, all right, so I'm not aware of data that suggests that you need to stop anticholinergic inhalers. That's a really good question. Because presumably they still could be absorbed in the bloodstream and go to the brain, but I think the dosing is a lot less than when you're taking it orally. So I believe the answer is no, but I don't know if that's been really extensively studied.
And do you have any opinion on Prevagen, OTC?
Prevagen. I have heard of it. There's no data in PubMed about Prevagen OTC.
And what other street drugs would be considered as risk factors for dementia?
What other street drugs be considered? So all the risk factors for heart disease are also risk factors for dementia. So if you have, a lot of cocaine or methamphetamine use, presumably you are, accelerating vascular disease and causing that. And then we talked about alcohol. I think those are the big ones. I don't know if it's really like some of the other like MDMA and that kind of stuff. I don't know if that's really been looked at. And of course for that, you know, if people are really hardcore abusing medications, you know, there's just a lot of other stuff going on that might be hard to tease out the effect of the drug from the, you know, poor diet and living on the streets and stuff like that. If they're living on the streets.
Can normal pressure hydrocephalus be triggered by psych meds?
Can normal pressure hydrocephalus be triggered by psych meds? Well, I don't think it would be triggered. I mean, what I would say is any medication that causes delirium or has the potential to cause delirium could unmask a disease that was just kind of barely floating there. But neural pressure hydrocephalus is not usually subtle. I mean, usually you're having gait abnormalities and things like that. So it's hard for me to go through a mechanism whereby which a psych med would cause you to go from like normal gait to abnormal gait. So I don't think it would trigger that, no. But psych meds in general may unmask what was already there, particularly with Alzheimer's.
Can you comment about dementia in cortical basal degeneration?
Oh yeah, so dementia and cortical basal degeneration. I would, so it's a form of frontotemporal dementia, and it tends to have some of the symptoms of frontotemporal dementia, and then it also has symptoms of the cortical basilar disease. So it's kind of an amalgam of Parkinsonism and frontotemporalism, and a lot of these. So that's kind of why I put this up there. You know, if it's not Alzheimer's and it's one of these other things, so if it's not one of those top three and we're not, you know, we're confused about the diagnosis, a lot of times we'll get special imaging and we'll make sure a neurologist is following that patient, and we will kind of diagnose over time. But I'm trying to think specific examples of what the cognitive profile looks like. I think it can be kind of all over the map, but it tends to look more like, so they tend to look more like FTD with cognition, and but they have Parkinson features. So it's pretty rare, but we do see it.
And a question in Sitka about biomarkers, wondering if you could explain again.
Explain the first, just explain
biomarkers. I'm not exactly sure what.
Yeah, so typically we do, so I think they might be referring to lumbar puncture, so spinal fluid biomarker. So when do we get spinal fluid? I get that question a lot. So what I would say is most people don't get it. You can make the diagnosis with the clinical history and MRI, or maybe one other test. But when we get spinal fluid is usually when we're worried about either a rapidly progressive dementia and we want to rule out paraneoplastic or one of those kind of oddball things, or if they can't get a PET scan for several different reasons, they're diabetic, insurance company won't pay for it, but for some reason they'll pay for a spinal tap. Then what we're looking for in the spinal fluid are biomarkers for Alzheimer's disease. Amyloid protein goes down, presumably because it's all being bound up in the brain, and then tau and phosphorylated tau go up, and there are kind of set cutoff points in the spinal fluid. So you can make a diagnosis. It's sort of like almost like a pathologic, like what a pathologist would find if they took a piece of your brain. The next best thing is spinal fluid, coating the brain. It's mimicking what a pathologist may find. And you can make a diagnosis of Alzheimer's with spinal fluid. And again, you might also be, like I said, looking for some of these other things like lymphoma or paraneoplastic, again, kind of more rare stuff. But a lot of times when you're just like, I'm not sure what it is, you might get spinal fluid and look for kind of a once pass thing, and then they save the fluid, and then you can retest it for other stuff. Other biomarkers are coming. Amyloid PET scans are already available. They're just not paid for by insurance. They're kind of complicated because amyloid can just go up with normal aging. So it's kind of like that white matter question. It's like, well, does white matter make the diagnosis of dementia or not? It's like, well, kinda, but not in everyone. So amyloid is kind of the same way. And then tau tracers are going to be a game changer, guys, because then we will be able to make diagnoses of CTE and tau and all these things, because tau is not normal. Amyloid might be normal aging, tau is not normal. So tau imaging will be a game changer someday, I think.
Okay, and then are HIV/AIDS medications linked to developing dementias?
I have not heard that before, but if there's a study out, I am not aware of it. HIV is for sure. You know, there's a cognitive impairment associated with HIV. I guess the one thing I'd say is the medications for HIV can accelerate some of the metabolic syndrome, and the metabolic syndrome is slightly linked to dementia. So I guess there could be kind of a complex interplay there. But I don't know if it's been actively studied.
So any questions? We have no other questions on the chat. So any questions here? If not, thank you so much, Dr. Hanson.
Thanks for having me.
This was great.
Because that's good questions.